Welcome to Psych Talk for Primary Care Providers, where our esteemed faculty members will provide you with invaluable insights to seamlessly integrate into your daily practice. Today, we'll have Dr. Jeremy DeMartini talk to you about treating bipolar depression in a primary care setting.
Hi, everybody. I'm Jeremy DeMartini. I'm one of the TNT primary care psychiatry faculty, and I am a med psych residency program director at UC Davis. And today I'd like to talk a bit about the treatment of bipolar depression. So the reason that I'm talking about bipolar depression is because it's a topic that's often complex and sometimes confusing for both primary care providers as well as even psychiatrists on what the proper treatment is. And the treatment is actually very different than unipolar depression. So in bipolar depression, before I get into pharmacotherapy, I want to just give you a quick reminder. The patient has an episode that's very, very similar. It meets all the same criteria as a major depressive episode. However, the patient has also had a hypomanic or manic episode. And this is a period of increased energy, increased activity, decreased need for sleep, as well as some other associated psychiatric symptoms. And this happens at minimum for 4 days, but typically on average, manic or hypomanic episodes can last weeks to months. So, when we're treating bipolar depression, it's really important to do psychoeducation with our patients, talk to them about the diagnosis, talk to them about, proper treatment, talk to them about triggers, what they can do in terms of sleep hygiene, in terms of having a regular schedule, in terms of they're probably going to need to switch their medications around if they flip from a maintenance mode over to a depressed mode versus a manic or hypomanic episode. So now let's focus a bit on the pharmacotherapy for bipolar depressed episodes. So in these episodes, the 5 FDA-approved options are all actually atypical antipsychotics. One of them is in combination with an SSRI. This is very different than unipolar depression, where you're going to be using antidepressants for depression. So in bipolar depression, you're actually focusing first with atypical antipsychotics. And one of the most commonly prescribed is going to be quetiapine. Quetiapine is a good medication because it's been around for a while. It's very available on most formularies. It's generic. The downsides to quetiapine is it tends to be a bit more sedating, can have a bit more weight gain. Average person will gain 7 to 10 pounds over 10 weeks. The next medication I would think about after quetiapine would be lurasidone. Lurasidone just recently became generic, so now is on most formularies. And lurasidone has an advantage to quetiapine in that it is weight neutral. It is one of the only antipsychotics that is weight neutral. Ironically, even though it's weight neutral, it has to be taken with food. Somehow I always remember that. And it can cause a little bit more GI distress than the quetiapine. I think, those are going to be kind of the mainstay for most patients in primary care psychiatry. There is a third drug that is not commonly as prescribed, and I think it kind of has to do with the branding of the drug. It's a drug called Symbyax, which is actually just a combination of a generic olanzapine mixed with fluoxetine. And it comes in these strange doses. It comes in 6 milligrams of olanzapine and 25 milligrams of fluoxetine as starting doses, which is different than the generic. So I say if you can't get that on your formulary and you want to use that drug, it's probably okay to just go with the next closest dose, which is going to be your 5 of olanzapine and your 20 of fluoxetine as starting doses. Olanzapine is actually probably the most or second highest risk of all the antipsychotics in terms of metabolic syndrome. Average patient will gain about 10 pounds over 10 weeks. So that's another reason why I don't put that one as first. Our other 2 drugs that are FDA approved for bipolar depression are much newer on the market and are not going to be on as many of your formularies. They're going to be expensive. They might be $3,000 or more a month if they're not covered by insurance, and you most likely will have to try to do a prior authorization. And if you're going to do that, you want to show that the patient has failed with 3 cheaper drugs before those. Those medications are going to be cariprazine, also known as Vraylar, and lumapipterone, which is also known as Caplyta. These are the 2 new medications. They have moderate risk of extrapyramidal symptoms and weight gain. They're kind of somewhere in the middle of the other ones. And I think they're effective medications, but again, I just prescribe them later, primarily due to cost. I wanted to give a quick plug for what is not going to be the standard for evidence-based treatment for bipolar depression, and that's antidepressants. There was a large randomized trial called the STEP-BD trial done in New England Journal in 2007. In this trial, they actually found that antidepressants, when given to patients with bipolar depression, did not improve response or remission rates for depression. Ironically, those patients also didn't get more hypomanic or manic symptoms. However, these patients were already on mood stabilizers, including atypical antipsychotics. Finally, there are some mood stabilizers that are out there for bipolar depression, but not as commonly prescribed by primary care. They're actually not FDA approved, so their use is going to be off-label, and they're going to require more monitoring. Those are going to be lithium, valproate, and lamotrigine, which again, those drugs are more approved for maintenance or manic phases.